having me. I know I'm standing between you guys and a break, so I'll try to keep it interesting and quick. So this study was really born out of having a pediatric case that needed intrathecal ampho, and there's really great guidelines by our colleagues at Kern County about how to use intrathecal ampho in adults, but not as much data in pediatrics, so we wanted to look back at some of our cases. So as we all know, coccidioidal meningitis is the most severe form of disseminated coccidioidal mycosis, and it was uniformly fatal prior to the introduction of intrathecal amphotericin and then later triazoles. Intrathecal amphotericin has been shown to stabilize and achieve clinical cures in adults, and the first case was described in a pediatric patient in 1959 by Dr. Wynn. There's been two great series of children hospitalized for coccidioidomycosis in the literature, and in disseminated cases, CNS involvement can be present in up to 37%, and a lot of hydrocephalus in those cases as well. But the use of intrathecal amphotericin in children is pretty scarcely described, usually isolated cases, or mentioned within these case series. And the dosing, the route of administration, and the duration of therapy can pose pretty specific challenges in pediatrics that we might not see in adults. For example, they do have unique anatomy, there's unique neurosurgical considerations and expertise required. Our pediatric patients might not always be able to communicate adverse effects they're having from intrathecal therapy. And in our experience, they have needed hospital-based administration to receive this therapy. And so we looked back and reviewed 4 instructive pediatric cases over the past 30 years to help provide some guidance on how to use intrathecal ampho in pediatrics. And so we abstracted these cases from our EMR at UCLA. We did a literature review to look for other cases of IT ampho use, and then included 2 previously published pediatric cases in our table. And so the first case I wanted to tell you guys about is a 5-year-old girl who came into an outside hospital with 2 months of intermittent fevers, fatigue, and a new onset seizure. There she had a CT brain that showed hydrocephalus. And here you can also see the transependymal edema surrounding the ventricles. And the CSF that was obtained from an emergent extraventricular device that was placed grew coccidioides, and she had a VP shunt placed. She had other sites of dissemination, and at the outside hospital, she was initially treated with fluconazole, liposomal amphotericin, and dexamethasone for 2 months. I'm not sure if this is related, but temporally 2 weeks after stopping ambisome, she developed new fevers, seizures, a worsening MRI, and this is her MRI on admission to our hospital at UCLA. This is a post-contrast T1 image, and you can see that she has pretty significant basilar meningitis with nodular leptomeningeal enhancement. And when our radiologists saw this, they were really impressed by the severity of disease, unfortunately. So by the time she got to us, she was obtended and required intubation from a neurologic perspective and required multiple AEDs to stop her status epilepticus. We got some CSF samples for her, and the main thing I wanted to highlight here is when we sampled the ventricular shunt, her CSF profile looked actually kind of normal, but then we were able to get our radiologist to do a cisternal tap, and not surprisingly, that was extremely abnormal. Unfortunately, we weren't able to get a white blood cell count on that. And then this cocci CSF complement fixation was incredibly high on the cisternal tap, but was actually normal on our ventricular sample. But the ventricular sample did go on to grow coccidioides, and those are the susceptibilities there below. And so since she had clinically failed fluconazole, we did transition to her to Isavu when she came to our hospital. But it was hard to get her to what we thought would be a therapeutic dose. And ultimately, she did require a bit of a higher dose than we normally use. And then at this point, we did initiate IT Ampho B for her. She was 5 years old. We started at 0.1 milligrams per dose with 18 milligrams of hydrocortisone. And because she was critically ill, really non-responsive, we did increase the dose every 3 days until we were able to get up to 0.5 milligrams. Initially, neurosurgery didn't feel comfortable placing a cisternal reservoir for her, so we had to use a VP shunt. We used pre-medications that were previously suggested in the literature, and we also used concurrent systemic steroids. And our allergy and immunology colleagues also started interferon gamma and dupilumab for her. She did get a cisternal catheter placed after 8 weeks. When we placed the cisternal catheter, we again reduced the dose to 0.1 milligrams, as is recommended by experts. And we did see toxicity again at a lower dose than what she was tolerating via the VP shunt. Unfortunately, the cisternal cath became non-functional after only 2 weeks, and we had to continue the IT Ampho through a new ventricular Ommaya. And so she was in the hospital for an extremely long time. She had really poor neurologic recovery. She was requiring supportive care, but she did get better during this time for a little bit. And when she turned 6 years old, which is about 11 months into her hospitalization, because she still had pretty severe disease, we added alorifim to the regimen via compassionate use, and that was the youngest age that we were able to use it at. Unfortunately, about a year into her hospitalization, she developed a recurrent C. diff infection. This caused abdominal distension and a new hydrocephalus concerning for shunt obstruction. And even when we removed the shunt and placed the EVD, she progressed to a really unresponsive state and developed hypoxic ischemic injuries on MRI. And her family decided to compassionately withdraw care for this patient. Another case we wanted to tell you about was a 10-month-old who initially presented to an outside hospital with a chronic nodular lip lesion that was actually present for 6 months before he presented to care. And during this time, he also had failure to thrive and developmental regression. Initially, he presented to an outside hospital where there was suspicion for cocci, and an MRI showed very severe basilar meningitis, hydrocephalus, and spinal cord disease. And he had sites of dissemination. He had a lot of sites of dissemination. At the outside hospital, he had a shunt placed and was started on fluconazole and ambisome. And then at the outside hospital, he had progression of disease with new seizures. His serum cocci-CF titer rose significantly, and so he was transferred to UCLA for further care. By the time he got to us, his lip looked like that bottom lesion, and we were able to get dermatology to do a biopsy, and that did grow coccidioides. So initially, he was just managed on isavuconazole, again, given our concern for fluconazole failure. And that's good that we did, because when we got back susceptibilities later in his course, the fluconazole MIC was elevated at 16. And he also required incredibly high doses for his age at 10 months. And we did some metabolism studies that did not show any altered metabolism. After 2 months of changing to isavu, he was clinically doing well, but we repeated imaging and CSF studies, and his MRI and his CSF titer looked a lot worse. So at this point, we decided to initiate IT Ampho for him. And he did successfully get a cisternal omaya right off the bat, and he was initiated at 0.05 milligrams. And we were, again, up titrating him pretty quickly, which he did tolerate, to a max of 0.5 milligrams daily, which he received for about 3 weeks. And we gave concurrent steroids and immunologic therapy as well. And so for him, he demonstrated clinical and radiologic improvement after about 6 weeks. And after the initial 3 weeks of daily therapy, we had decreased to 3 times a week therapy, and we saw a nice decrease in his CF titer. As a reminder, it was 1 to 512, and then it came down to 1 to 32. And then at that time, he was having some more fevers. We didn't find any other infection that was causing it, no other medications that were related, so we were concerned it could be related to the AT Ampho, and so weaned him down to twice a week, which he tolerated well, and then after a month, down to once a week. And initially, because he had been doing well clinically, we actually planned to stop AT Ampho after these 3 months of therapy, but his CSF culture, right when we were discharging him, ended up growing coccidioides again. Then we got cultures from his sternal omaya, which was negative, but his VP shunt culture was positive again twice. And so we thought this was likely a shunt biofilm on his VP shunt, and ended up exchanging it and then continuing the AT Ampho via the cisternal omaya for another 3 months. We, again, we're going to stop at this point because he was clinically really progressing well. He's meeting a lot of new developmental milestones, but we did a repeat brain MRI that showed worsening leptomeningeal enhancement. And so recently we had to switch him again to twice a week therapy. And of course, he'll stay on isavu for lifelong therapy. And so these were just 2 of our cases, but we did find 2 others in our hospital in the last 30 years, which are the first 2 columns. And then patient 5 and 6 are patients reported in the literature, one from Valley Children's and one from CHLA local to us. And the main things I wanted to highlight with this table is there was some variability in the initial dose, but all of the patients, regardless of their age, tolerated at minimum 0.3 milligrams of a final dose. So probably most patients, even in pediatrics, will tolerate a 0.1 milligram dose. The route of administration was also extremely variable and really depended on what our patients could tolerate, but cisternal omayas were present in at least 3 of the patients. And then there was also a lot of variability. Only half of them got concurrent intrathecal steroids, and about half got concurrent systemic steroids. And then the duration of therapy was incredibly variable as well, as little as 12 days for one patient who unfortunately did not do well, but up to 9 months and ongoing for the patient that we described. And so overall, cocci meningitis in pediatrics can be hard to diagnose, and there's some unique management challenges. We recommend considering it in infants with idiopathic or acquired hydrocephalus, especially if they're in an endemic area. And in our young patients, it might be hard to diagnose cocci meningitis until you actually start seeing signs of increased intracranial pressure. So we might have a lower threshold to obtain CSF studies in a young patient, especially if we're seeing other signs of disseminated disease. And it's really important where you collect the CSF from, because it has to be below the site of disease. So really cisterna or lumbar fluid will be more accurate than ventricular fluid, since it's mostly a basilar meningitis. Initial therapy for cocci meningitis by the AAP is still recommended to be high-dose fluconazole, but you might want to change this therapy if you're not seeing improvement in your CSF markers or your neuroimaging. And for mild changes or stagnant parameters, you might optimize your fluconazole dose or switch to another mold-active triazole. But patients who are really having severe neurologic changes or significantly worsening parameters, you might want to consider rescue therapy with intrathecal ampho for these pediatric patients. And so initiating IT-ampho is really a multidisciplinary effort. You have to talk to your pediatric neurosurgeons, really find someone who's comfortable with this administration, talk to pharmacy, make sure the primary team knows what kind of monitoring to do. And as I mentioned, preferentially, we would recommend using a cisternal OMIA, but that's not always possible. We can't do direct cisternal injections in young children because of the sedation needs. It's just not going to be well tolerated, and not a lot of expertise in administering in that way. But a cisternal OMIA at least will allow ampho to be instilled closer to the primary site of infection. But these cisternal reservoirs have a shorter functional life and can be technically challenging to place, so you really need to have a neurosurgeon who's willing to do it. And if not, you might need to administer via ventricular OMIA or using a VP shunt. In older patients, it has been described to use regular LPs, especially if they're just down to once-a-week therapy. And then we talked about restarting at a lower dose if you're switching between the site of administration. And then in terms of what dose to start with, so we do know that CSF volumes approach adult volumes by the time kids are age 3 to 4. And at that point onwards, starting at 0.1 milligrams has been previously described in adults as reasonable. But that might be reasonable even in younger patients, since even our younger patients tolerated at least 0.3 milligrams. Of course, we do recommend mixing it with hydrocortisone, as is the adult experience. And of course, you're mixing it with D5W. And then we did end up rapidly escalating our doses in our pediatric patients compared to what's described in the adult literature. And this was really due to critical illness by the time we were starting it. And your final dose is really going to be based on patient tolerance. We didn't end up going above 0.5 milligrams, but the CHLA case did describe tolerating up to 1 milligram. And then we did start with daily IT-ampho in the adult literature. It's often started 3 times a week, but we did decrease to 3 times a week as soon as our patients were more stabilized. And so overall, adults can receive outpatient IT-ampho over months to years and can be curative or give a sustained remission, but it's really not feasible in our pediatric patients, and the recommended duration and steps for de-escalation are not standardized. It's hard for us to do prolonged therapy because we don't have enough experienced neurosurgeons, and keeping them hospitalized just for IT therapy can really prolong their hospitalization. We have been successful in doing outpatient therapy by admitting our patient for weekly 24 or 48-hour admissions, but again, that's a big burden on the family. And so we do propose using IT-ampho in pediatrics as more of a stabilizing measure rather than a curative measure until you're doing well enough on azole monotherapy. And a huge thank you to my co-authors and to our colleagues at UCLA, including our immunologists and our radiologists and neurosurgeons. Thank you.
All right, we have time for a question for Reba.
That was a wonderful talk. I was wondering, listening to Dr. Thompson's talk prior to yours, all of your patients first got better and then got worse. Is that this paradoxical reaction happening in children? And if that's the case, is it worse or not?
Yeah, I think they did have a progression of disease. I'm not sure if they fully got better, but they were stable for some time and then progressed. And I was really interested by his talk because we did use alorifim in that one patient, and she did do a lot worse after starting it, but we didn't think it was related because it was very mechanical related to the BP shunt, we think. But good question.
Thank you so much for a wonderful, wonderful talk, presentation. I learned so much. What is the MIC of amphotericin B for cocci? Because it seems the concentration in the CSF is too low, 0.1 to 0.5 milligram seemed too low. It seemed to me sub-MIC level, and we don't even know how much that drug penetrates the brain tissue. So why are we dosing such a low dose of Info-B, and what is the tolerability of higher dose? You mentioned tolerate up to 1. What is the intolerability? What are the signs of intolerability? And why are we giving such low dose?
The
CNS?
MIC is usually less than 0.03 milligrams per ml, and so you do still get a good concentration with 0.1 milligrams, but we just use that as an initial dose to see if they tolerate it and then go up and titrate from there. But most patients do tolerate it from our experience, so potentially you can get up to a higher dose quickly, but there still should be some benefit even if you're only able to tolerate those lower doses.
Any data in terms of brain tissue penetration? Because we know M4B is very concentration dependent, killing effect. So is there any data? No? Someone?
So,
Sorry.
if I
maybe
might
someone
try and answer
can
that
comment
question.
better. Thank you.
So, there's a definite tolerability issue, and hardly anybody these days seems to get above 0.2 in our practice. I did have one patient that tolerated 0.8, but it isn't each dose. This isn't like penicillin for meningococcemia. Amphotericin is highly hydrophobic, and it comes out of aqueous solution, and the model is, but no proof, is that it's plating itself on the meninges, and that's where the cocci lives.
Thank you
And,
so
and
much.
so it's cumulative.
Issue that the neurosurgeons will let you
Yeah.
know about. So Twee, sometimes you just can't give more, and we had a patient at
Yeah.
Mayo where volume absolutely precluded giving higher doses. Go ahead.
Yeah.
Thanks for sharing your experience. I know your focus was on the antifungal management and IT amphotericin specifically. I wondered if I could ask about your role, your experience with using immunotherapy, particularly the timing and impact you thought. I think you mentioned both of your cases actually got Dupixent
They did.
in relative passing. I don't know how that was decided. Again, anecdotal on 2 cases or maybe a few more on
I'm
what
going
you
to call
saw.
her up, but find Dr. Garcia Lorette. She's here from our immunology team, and she can tell you a lot about it. It's pretty unique to UCLA, and it's based on our immunologist's prior experience treating a very ill patient with dupilumab, but I think there's still a lot of study that they're doing to prove the efficacy, so talk to her. She's great. Yeah.
What day is the poster for that
Yeah,
presentation?
there she is.
Maria, what day is your poster? It's today.
Yeah.
So shout out for the posters. Well,
Yeah.
we're running over, so thank you, Sanchi. Excellent presentation. So